going to be going over some IV solutions. Now, there are two major indications typically for pre-hospital IV therapy. So to replace fluid loss or to provide a route for IV medications. Now, when we're talking fluid loss, keep in mind that pumping them full of normal saline and lactated ringers, D5w, any of these things do not constitute replacing oxygen carrying capabilities. So even though you may get a higher, not necessarily better, but a higher blood pressure, it doesn't mean you're actually improving their overall hemodynamic status. In fact, you can be making it worse. I would be remiss if we talked about fluids and we did not talk about the lethal triad. So you may be familiar with the lethal triad in trauma. Hypothermia, acidosis, and coagulopathy all indicate a higher mortality rate. Well, guess what IV fluids cause in large quantities? Hypothermia, acidosis, and coagulopathy. So it's very important to remember that when we're giving fluids, look at why we're giving them. Do they need them? We don't just give fluids just for the sake of giving fluids. It is not just some harmless thing. You can absolutely hurt or even kill somebody by giving them too many fluids. Now, I'm not saying don't give them fluids if they need it. Just make sure that you know why you're giving them IV fluids before you just willy-nilly start giving them fluids, okay? Now, when we're talking about pre-hospital IV fluids, there are two major types or classifications of your IV fluids, and these are going to be colloids and your crystalloids. Now, your colloids are these large proteins. That's a higher molecular weight. They don't diffuse across the cellular membrane like the crystalloids do. So we don't typically see these used in the pre-hospital environment. I'm not going to say you're not going to, but typically you don't see these very often. So kind of your prototype here that we're going to talk about, so plasma protein fraction or your plasminate. And so what this is this protein containing colloid, and it's suspended in like this saline solution. All right, it's very, very expensive, has a very short half-life or shelf life, and it's not really used pre-hospital very often. Now, how it works is it's actually going to increase that intravascular volume by attracting water from the other fluid compartments because of the osmotic pressure that it creates. All right, your indications are going to be like your hypovolemic shock, especially in burns, or hypoproteinemia, which is a low protein state because obviously it contains proteins. Contraindications. There aren't really any major contraindications when used or in a life-threatening emergency or situation. Now, the more common ones that you will see are your crystalloids, and these contain water and electrolytes. So both water and electrolytes pretty readily diffuse across the cellular membrane, which makes it a lot easier to use. It's also much less expensive when compared to colloids and things like that, and it has a much longer shelf life. It lasts a lot longer. Now, these crystalloids are going to be classified by their tonicity, whether they are isotonic, hypotonic, or hypertonic. Some things may be considered or classified as an isotonic in the bag or hypotonic in the bag, but then they may change as they diffuse across very readily. All right, so your isotonics have almost the same osmolarity as your fluid serum and your bodily fluids, and this is not going to cause an overall fluid shift to or from other compartments. So lactated ringers, typically if we give this, they've lost a fair amount of blood or something, and it is not going to cause an overall shift in fluids. D5w, 5% dextrose in water. It is considered isotonic in the bag, but in the body it actually is hypotonic. So you may see it referred to as both. Don't let that confuse you. Now your hypertonic, this is where it has a higher osmolarity, so higher concentration than the body. This is going to pull fluid from the intracellular and intestinal compartments to that intravascular compartment. This is good for helping stabilize blood pressure, increase urinary output, and reducing interstitial edema. You must be very careful, though, monitor very carefully not to overload the patient with fluids. Now your hypotonic is going to be a lower concentration of sodium than the cells, and this is going to hydrate the cells while depleting the vascular compartments. It's going to pull it out of the vascular space and into the cells. And this can cause a very sudden fluid shift from that intravascular space, causing what they call kind of third spacing. So this is an abnormal shift. All right, your half normal saline or 0.45% sodium chloride would be your kind of prototype here. So let's talk about some solutions. So lactated ringers. Okay, this is an isotonic crystalloid. It contains electrolytes and it has lactate as a buffer. All right, indications are going to be hypovolemic shock. and if you need a TKO IV. Contraindications: do not use it in a patient with congestive heart failure, renal failure, or in severe hemorrhagic shock. Your dosages: it depends on protocol to maintain perfusion to the vital organs during shock without diluting their clotting factors or fluid overloading the patient. So there is no one set exact amount. It's going to depend on your patient. We're aiming for a MAP, a mean arterial pressure, for about 65. All right. Once that target perfusion state's is met, then we want to reduce that infusion overall. Now, it is important, worth noting, we talked about the isotonic and hypotonic and hypertonic, and this is isotonic, which is good as far as moving fluids, right? But your pH of your lactator ringer solutions is going to be between 6 and 7.5. So this is going to be the closest to a normal pH of the 3 major fluids that you will see in the pre-hospital setting. Precautions: monitor the patient for circulatory overload. All right, how we're going to see that? Typically, we're going to start seeing or hearing signs of pulmonary edema. It's going to be one of the earlier places that you'll see if they've got circulatory overload. Your side effects are rare in therapeutic doses, but once again, they could include your circulatory overload, pulmonary edema. And your interactions are few in the emergency setting. So let's talk about D5w now. It is a hypotonic solution, and it's going to help prevent that circulatory overload in patients because it's going to help fluids kind of move out of the intravascular space into the cell space. And it's also going to provide nutrients as sugar. Indications: IV access for emergency drugs and for dilution of some drugs for intravenous infusion. Contraindications: we do not use this as a fluid replacement for a hypovolemic state. That's going to hurt the patient. All right, your dosage: sit through a mini drip, just a TKO to meet the patient's needs. Precautions: it is acidic. It may produce local irritation in the veins, and if you have extravasation, which is where basically a blown IV, it can result in your tissue necrosis. Watch for your signs of circulatory overload. All right. If you are treating hypoglycemia, you want to try to draw a tube of blood before you give your D5 or D50. All right. Your pH, remember we talked about it's acidic. Your pH for your D5w is at 3.5 to 6. Remember, normal pH of the body should be between 7.35 and 7.45. So you can see if you give too much of this to a patient, you can cause some very severe problems in them. Your side effects: rare in a therapeutic dosage. Interactions: you do not want to mix this with phenytoin or dilantin or Inocor. All right, it can cause a precipitate to form. Now, your normal saline, 0.9% sodium chloride normal saline. It's an isotonic crystalloid. Okay, useful for heat strokes, heat exhaustion, DKA. It replaces your fluids and your electrolytes. Your contraindications: we don't really want to use this in a patient with heart failure if we can avoid it, because circulatory overload can happen very, very rapidly. Okay, as far as dosage goes, the situation is going to dictate how much you give. Like the other ones, this one is on the acidic side, and your pH range for normal saline is going to be between 4.5 and 7. So once again, it is on the acidic range, so you can absolutely hurt your patient if you give them too much of this. Your precautions: when you give large amounts, you may have some other essential electrolytes that become depleted or essentially diluted. All right. If you're given large amounts of fluids, you probably would want to use lactated ringers before you would use normal saline. All right. Now, important note here: sterile normal saline for irrigation should not be confused for IV administration. So just keep that in mind if you're looking at those usually come like a plastic bottle or something like that instead of a bag. Side effects: rare in therapeutic dosages, and there are few interactions in the emergency setting. Now, when we're talking about all of these fluids, we want to think about the IV catheter, right? So what size catheter should be inserted? How much fluid are we going to be giving them? You know, if we're not going to be giving them blood products or colloids, or if we're doing just crystalloids and we don't need a large quantity, is there any reason to do an 18, a 16, a 14? Maybe not. You know, what kind of IV catheter? Could we do just a INT or a J-loop? Could we do just a hub? Do we need the full line of fluids? What type of fluid do we want to use? What are the criteria? Are they in risk for circulatory overload, heart failure? Are they severely dehydrated, or are they hypovolemic because they're bleeding out everywhere? All right, so these are all the kind of things that we want to think about when we are making the decision to start an IV, but also to give them any kind of fluids.